Good morning. A warm welcome to Online Anaesthesia Postgraduate Teaching Program and Zoom platform, sponsored by Akrulla and hosted by A1 Logics and aired by Anaesthesia TV. Today we are having two important topics, that is pharmacokinetics or pharmacodynamics of local anesthetics by Dr. Aishwarya, and that will be followed by multimodal analgesia by Professor G.K. Kumar, a good friend of mine. Today session is coordinated by Dr. Rajesh J. Prakash sir. Over to you, sir.
Thank you, sir. Good morning, one and all. Today's topic is very important for postgraduates, both for theory and also for clinical practice, and it is important topic for practitioners too. So we'll start with the first session, and the topic is basics of local anesthetics, pharmacokinetics and pharmacodynamics of local anesthetics, which the lecture will be delivered by Dr. Aishwarya, who is a senior assistant professor in Department of Anesthesiology, Pain and Palliative Care, Government Medical College, Pomodurar, Chennai. She graduated from Viswanathan Medical College from Trichy, and she's a best outgoing student in 2016 from there, and she's a gold medalist. And she had finished her both the pain and palliative care fellowship programs, and pain fellowship from Daradia Pain Clinic, where me and Dr. G.K. Kumar also got trained from there only. Over to you, Dr. Aishwarya, for the topic of pharmacokinetics and dynamics of local anesthetics.
Thank you, sir. Good morning. Today I'm going to talk about local anesthetics. The agenda of our talk is we'll embark upon the history, mechanism of action, classification and basic pharmacology of local anesthetics, pharmacokinetics, uses, additives, pharmacodynamics and side effects, and local anesthetic toxicity. History of local anesthesia, we all know that cocaine was the first local anesthetic to be used. It was isolated in 1859 by Niemann. And
we make it as a slideshow.
Yeah, it is in presenter mode.
Okay, sir. Yes, sir.
Yes.
Yes, sir. Halsted in 1884 used it for regional anesthesia, and in 1943, Lofgren synthesized lidocaine, which is still in use. Coming to the mechanism of action of local anesthetic, we first need to know the nerve impulse conduction and how the voltage-gated sodium channels work. So this is a video showing nerve impulse conduction. When a stimulus is applied in a nerve cell in the axon, the sodium channels are activated, and the sodium comes inside the axonoplasm, and it becomes more positive internally, and an action potential is generated when a threshold potential is reached, and it is propagated forward by subsequent the wave of depolarization, which opens the subsequent sodium channels, which allow the influx of sodium ions into the axonoplasm. It is the wave of depolarization is usually unidirectional. It is because the backward progression is stopped by the opening of potassium channels, which help in repolarization of the nerve cell. This is an myelinated nerve fiber. You can see that myelin acts as an insulator, which prevents the dissipation of the conduction of nerve impulse. And so the nerve impulse jumps from one node of Ranvier to another, which has a lot of concentration of sodium channels. And this is called saltatory conduction, which helps in the fast conduction of nerve impulses. voltage gated sodium channel is located in all excitable cells, and it is responsible for the action potential generation and propagation. It activates with changes in the nerve fibers, changes with the membrane potential. And you can see each sodium channel has an pore forming alpha subunit, and each alpha subunit has 4 domains, and each domain has 6 transmembrane helices. These are important because these form the activation and the inactivation gates and the selectivity ports. This is a video showing how the voltage gated sodium channel usually acts during a membrane potential. And these are the 3 states in which the voltage gated sodium channel is present. It's usually in the resting state initially, and this minus 70 is the resting membrane potential. When there is a membrane potential generated, when the threshold potential is reached, there is more of accumulation of sodium ions inside, and which repel the positive selectivity pore, and it helps in opening the gate, and more of sodium ions are entering inside the axonoplasm. And this is when you can see in that action potential, this is when this voltage gated sodium channels are opening, it forms the peak of the action potential. And when enough amount of sodium ions are accumulated inside the axonoplasm, it becomes relatively more positive, and it activates the inactivation gate, which plugs the channel. And so there is no more input of the sodium ions. And this is the absolute refractory period where it cannot conduct the nerve impulse. Immediately following the closing of the inactivation, closing of the inactivation gate, there is an activation of the potassium channels, which accumulate in the outside of the nerve axon, and which again creates a difference in the membrane potential across the lipid bilayer. And so this again puts the channel into the resting membrane state. So now it can be activated by any impulse. This is where the local anesthetic acts. This is a receptor located in the alpha subunit. It is present in the intracellular part of the voltage gated sodium channel. Local anesthetic usually causes a reversible conduction blockade by combining the actual part of the local anesthetic, which combines with this receptor, is the cationic form. Whenever a drug is injected, the drug has to be in this unionized form to go through this lipid bilayer, and inside the axonoplasm, it becomes ionized, and this ionized part of the drug only binds with the local anesthetic. When this local anesthetic binds with the receptor, it prevents from entry of the sodium ions into the channel, and hence causes the conduction blockade. The binding of the local anesthetic to the receptor stabilizes the channel in the inactivated state. The frequency-dependent blockade or a phasic blockade is nothing but whenever a local anesthetic binds with an open sodium channel or an inactivated sodium channel, there is increased affinity, which causes increased blockade of the action potential. A resting membrane, resting conformation of the sodium channel has very little affinity for the local anesthetic. So whenever there is a wave of depolarization, when there is an increased frequency of waves of depolarization, the local anesthetic binds much better, and there is much more inhibition of the action potential. This is called the modulated receptor model. And the guarded receptor model, it also means that whenever there is when the local anesthetic binds to an open or inactivated channel, there is, even during the recovery, it is in a more stable state, and there is a slow diffusion of the local anesthetic from the receptors, and this helps in a prolonged blockade. Nerve fiber susceptibility to local anesthetic. As you see, the small myelinated nerve fibers, they are better diffused and by the local anesthetic, and they are the first to be affected by the local anesthetic. And you can see that A delta, A gamma are the first fibers to be affected, and then come the large myelinated nerve fibers, A alpha, and the most resistant to the blockade is the C fiber. there is a lot of controversy regarding the susceptibility to local anesthetic. Initially, it was thought that C fibers, which are unmyelinated, are more susceptible to local anesthetic, but it is the reverse. They are more resistant because due to their differences in their conduction ability. So the most fast conducting fibers and which are of smaller diameter are first block, are more susceptible than the C fibers. And the recovery is also fastest from the smallest unmyelinated nerve fibers and the reverse manner. You can see that most of the time when you give a local anesthetic blockade, the distal fibers are distal regions are blocked the last when compared to the proximal regions. It is because of the nerve fibers which are located, the distal nerve fibers are located more inside the core of the nerve fiber, whereas the proximal fibers are represented in the periphery of the nerve fiber, and hence the periphery is first diffused by the local anesthetic, and hence it's first block, and then the core fibers, which are the distal regions. You can see that the differential sensitivity is very much demonstrated in an epidural blockade. When you give an epidural anesthesia, you will first see that the cold sensation is lost, and then the pink prick, which is a sharp pain, and only then the touch and the motor fibers. Classification of local anesthetic. Local anesthetic is essentially an aromatic ring it contains, which is an hydrophobic part of the local anesthetic, which helps in this diffusion. And then it is linked with an hydrophilic secondary amine. And this linkage is either an ester type or an amide type. An ester type is essentially COO. And you can see that procaine is an example. The other ester-linked local anesthetic are benzocaine, cocaine, tetracaine. And when you come to amide type of local anesthetics, this is a commonly used one, the lidocaine, bupivacaine, ropivacaine, articaine, all these things. You can see this is the classification based on whether they are injectable or surface anesthetic. The injectable anesthetic, whether they have low potency, intermediate potency, or high potency. Short duration of action, low potency, short duration of action is the procaine, chlorprocaine, articaine. And intermediate potency and intermediate duration of action is the lidocaine, prilocaine. And high potency and long duration of action consists of bupivacaine, ropivacaine. The local anesthetic properties which affect the pharmacokinetics are these pKa, which determines the onset of action. The lipid solubility determines the potency. The plasma protein binding determines the duration of the action, and the metabolism decides the elimination of the drug from the body. You can see pKa is the pH at which 50% of the drug is ionized and 50% is non-ionized. The local anesthetics are essentially weak bases. So in physiological pH, the local anesthetic which has a pKa very near to the physiological pH has the most rapid onset of action. The drug in the unionized form is required to penetrate the lipid bilayer, and the drug in the ionized form is essential for the action at the receptor. And you can see that in acidosis, when in abscesses, local anesthetic is not preferred because there is due to infection, there is increased acidosis, and there is increased fraction of ionized part of the drug, which cannot penetrate the lipid bilayer, and hence there is a poor quality of anesthesia. This is a table which shows the percentage of ionized part of the drug in 7.4. You can see that bupivacaine is 83% ionized at 7.4, and hence the onset of action is little late compared to lidocaine, which is 76% ionized in the physiological pH. You can see that the lipid solubility is very high for etidocaine, bupivacaine, and tetracaine. All these local anesthetic have a very high potency. That is, a small amount of dose of drug can cause the blockade equivalent to that of the other ones which have a lower lipid solubility. The percentage of protein binding, you can see in bupivacaine, it is 95% protein bound. Ropivacaine is also very similar, 94%, and lignocaine is only 64%. So because of the increased protein binding, bupivacaine has a longer duration of action compared to lignocaine, which is only 64%. The routes of administration, we know we use it for local infiltration, IVRA bias block, spinal anesthesia, epidural anesthesia, perineural for all these plexus blocks, topical, ganglion blocks, and intrapleural. Coming to the pharmacokinetics of the drug, when you inject a drug, essentially it exists in an equilibrium between the ionized and the unionized, and it is taken out by this body. It is disposed by the body in 3 different ways, by non-specific tissue binding and uptake into the bloodstream, and only very little amount of the drug is available for the nerve blockade. And the one which is going into the bloodstream undergoes systemic tissue distribution just like any other drug, and it is eliminated either by the hepatic metabolism, such as in amide drugs, and ester drugs undergo plasmahydrolysis, and then metabolites are eliminated in the urine. You can see in absorption, it depends upon the site of injection also. In sites where there is increased vascular supply, such as in intercostal, and the mucous membrane is highly permeable, tracheal, and IV, of course, bioavailability is 100%. So whenever in these areas there is increased systemic absorption of the drug, and hence there is an increased risk of toxicity in these drugs. So you have to be very careful with the maximum dose of anesthetics used, the lowest being the subcutaneous one. And we know that local anesthetic have an intrinsic vasodilator activity. Lignocaine has an intrinsic vasodilator activity, then that's why we use additives like epinephrine, which cause local vasoconstriction and reduce the systemic absorption. Coming to distribution, ester local anesthetics are very minimally bound because they are rapidly hydrolyzed, and amides are extensively bound. They are mostly bound to the alpha-1 acid glycoprotein with a high affinity to this albumin also. And protein binding is increased in pregnancy. It is increased in renal failure, infancy, in myocardial infarction, the post-operative states, which reduces the fraction of free drug available. The degree of protein binding will affect the degree of placental transfer also. When there is more of protein-bound drug, very little will be transferred through the placenta to the fetus. Whenever there is a fetal acidosis, the fetal environment is acidotic. So whichever unionized drug which comes into the fetus is essentially trapped due to increased acidosis, and ion trapping can occur in fetal acidosis. Coming to metabolism and elimination, ester local anesthetics are very rapidly hydrolyzed by the plasma cholinesterases to inactive compounds. And a few esters like procaine and benzocaine are metabolized into para-aminobenzoic acid, which are notorious for causing allergic reactions. An exception is cocaine, which is partially metabolized in the liver and excreted unexchanged in the urine. Amide local anesthetic almost all undergo hepatic metabolism. They are converted to aminocarboxylic acid and cyclic aniline derivatives. They further undergo hydroxylation and N-dealkylation. And an exception to this is an articaine, which undergoes metabolism through hydrolysis. The rate of amide metabolism depends upon the individual agent. Lidocaine undergoes faster metabolism compared to ropivacaine and bupivacaine. The factors affecting local anesthetic metabolism is very much dependent upon the liver for all the amide local anesthetic. Any reduction in the metabolic rate, like in cirrhosis of liver, there is a decreased hepatic function, and any decrease in the liver vascular flow, this is in congestive cardiac failure, any vasopressors or hypotension, H2 blockers, all these can predispose to systemic toxicity. Ester local anesthetic metabolism can be affected essentially only by a genetically abnormal pseudocholinesterase. Methemoglobinemia is an complication which occurs when you use prilocaine infusion for a prolonged time. It accumulates after large doses of more use when you use more than 10 milligram per kg. It is all the metabolites of prilocaine are converted into methemoglobinemia. So neonates who have received prilocaine epidural analgesia and labor analgesia are susceptible to methemoglobinemia. And benzocaine is a common ingredient in the local anesthetic sprays used that can also cause methemoglobinemia. In that case, the treatment would be methylene blue 1 to 2 milligram per kg of an 1% solution over 5 minutes, and the total dose should not exceed more than 7 to 8 milligram per kg. The uses of local anesthetic. We know that It can be used for topical, infiltration, neuraxial. We are very familiar with neuraxial intrathecal bupivacaine, where hyperbaric bupivacaine is used. Epidural, we can use lidocaine, bupivacaine, ropivacaine, and levobupivacaine. Field blocks, again, the same set of local anesthetic can be used. You can see that lignocaine is effective for peripheral nerve block in even 1% to 1.5%. Epidural anesthesia, we use 2% of lidocaine. For spinal anesthesia, 0.2%. It is generally not preferred for spinal anesthesia nowadays. IV regional anesthesia, the only indicated local anesthetic is lidocaine, 0.5%. And bupivacaine is used for local anesthetic infiltration at 0.25%. For spinal, we use 0.5% hyperbaric. And epidural, 0.5% and 0.75% can also be used. Peripheral nerve blocks, 0.375% to 0.5% is effective. Levobupivacaine has very similar characteristics of bupivacaine. Ropivacaine also is supplied commercially as a single enantiomer. It is also available as 0.2%, 0.5%, 0.75%, and 1%. This is a topical anesthesia where cocaine is used in concentration of 4% for ENT. Usually lignocaine is essentially preferred topical anesthetic. 2 to 4% solution is used for the oropharynx, tracheobronchial tree. Jelly is used in lignocaine jelly is used for urethral for all these catheterizations. 2.5 to 5% is used in ointment. And suppositories of 10% and aerosol, lignocaine aerosols are used in 10% concentrations. EMLA is eutectic mixture of local anesthetic of lignocaine and prilocaine. It is used on intact skin. It is used for, it has to be applied under compression dressing for around 1 hour prior to the procedure. It can be used essentially for an IV cannulation in an MI patient where you cannot allow the pain impulse. And this is the dosage of local anesthetic. Local anesthetic can be used without adrenaline and with adrenaline. With adrenaline, an increased dosage can be used because it reduces the systemic absorption. Bupivacaine is used in 2 milligram per kg. With adrenaline is 3 milligram per kg. Levobupivacaine is also very similar dose of bupivacaine. Lignocaine is 2 to 3 milligram per kg and 5 to 7 milligram per kg with adrenaline. Ropivacaine is 3 milligram per kg without adrenaline, and same with adrenaline also. The duration of local anesthetic, you can see in major nerve blocks. The major nerve blocks, we use 1 to 2% of local anesthetic, concentration of lidocaine. The duration of action is around 1 to 2 hours. Bupivacaine is used in 0.25% to 0.5%. It has a duration of action of 4 to 6 hours, and very similar with levobupivacaine and ropivacaine. With epidural anesthesia, lidocaine is usually bupivacaine is preferred. Bupivacaine again from 180 minutes, that is 3 hours to 6 hours. It is a very effective. With spinal anesthesia, essentially we use hyperbaric 8.25% of glucose added, 0.5% bupivacaine. Again, it depends upon the amount of volume we inject, 3 to 4 ml, 90 minutes, it comes up to 3 to 4 hours. Additives. The additives used are the most common one is the epinephrine, as we have already seen. It causes local vasoconstriction. Dexamethasone has synergistic action via the glucocorticoid receptor. The exact mechanism of action is not very much known. It is a very effective additive. It can prolong up to 12 to 24 hours. The local anesthetic blockade is prolonged by dexamethasone. Clonidine and dexmedetomidine, we all know it is an alpha 2 adrenergic agonist, and it also helps in increasing the duration of action of local anesthetic by 2 to 4 hours. And when you come to buprenorphine is essentially not used nowadays because of the increased systemic side effects such as vomiting, nausea. This is a table showing the common additives. Opioids are the common additives used in neuraxial blockade. We use intrathecal morphine, fentanyl, epidural fentanyl, and even clonidine is used in intrathecal. Lot of studies are going on that. Carbonation and pH adjustment of local anesthetic. Usually the commercially available preparations are hydrochloride salts of local anesthetic, which is which has an acidic pH. So on injection of these local anesthetic, it can cause pain due to this low pH and cold solution. So this soda bicarb will help in reducing the pain of the injection. And addition of soda bicarb has been found to increase the onset of action because it causes more of alkalization by increasing the pH and increasing the share of the uncharged local anesthetic, which can easily diffuse across the nerve cell. The recommended dose is 1 ml of 8.4% for any 10 ml of local anesthetic used. The pharmacodynamics and side effects go hand in hand. The effect on cardiovascular system, as you can see, local anesthetic block the cardiac channels and they decrease the maximum rate of phase 0, the phase 0 part of the cardiac action potential, which increases the PR interval and the QRS interval, and essentially the refractory period is also increased. It has a direct negative inotropic effect, and it is more pronounced with bupivacaine than lignocaine. There is also a spontaneous the depression of the spontaneous pacemaker activity at very high concentrations. The cardiovascular collapse to CNS toxicity ratio is lower for bupivacaine. That is, the cardiovascular side effects occur at a lower dosage for bupivacaine than compared to lignocaine. And in vascular system, we know that they have a biphasic response. At subclinical doses, these local anesthetics, they cause an vasoconstriction. But in clinically significant doses, they usually cause vasodilatation. Lignocaine may be used to treat ventricular arrhythmias while bupivacaine is not. It is because bupivacaine dissociates 10 times slower from the sodium channels which it has attached to, which results in persistent depression of this conductivity. This may lead to reentrant arrhythmias and ventricular fibrillation. And this tachycardia may enhance the frequency-dependent blockade by bupivacaine, which in turn adds to its cardiac toxicity. And it has an additional action on calcium and potassium ions, disrupting the conduction through these two, which leads to life-threatening arrhythmias. So how safe is ropivacaine when compared to bupivacaine? Ropivacaine has substitution of a propyl group for this butyl group in the bupivacaine, and it is a pure levorotatory stereoisomer. The lipid solubility is intermediate between bupivacaine and lignocaine. At higher concentration, the potency is equivalent, but at lesser concentrations, usually it is 40% less potent compared to bupivacaine. And it dissociates more rapidly from the cardiac sodium channels, and hence it is less cardiotoxic when compared to bupivacaine. And there is less myocardial depression, and it has higher clearance, and all these contribute to less cardiotoxicity when compared to bupivacaine. Effects on CNS. Local anesthetics penetrate the blood-brain barrier very rapidly, and they have a biphasic effect. Initially, the cortical inhibitory pathways are inhibited, and so it results in excitatory phenomenon. At lower doses, the initial manifestation of the toxicity is circumoral numbness, lightheadedness, nausea, and the subsequent disturbances are visual and auditory. You can see muscle twitching, and then they result in convulsions. And finally, all the central neurons are depressed, which lead to coma and apnea. During this convulsions, the patient is prone for hypoventilation, and the patient ends up at hypercapnia. Hypercapnia in turn causes cerebral vasodilatation, acidosis in the CNS and the cerebral region, which causes acidosis, and this increases the delivery of local anesthetic into that region, and which in turn causes ion trapping, and which is detrimental again. So we have to aim for normocapnia, and that's why we have to ventilate the patient when the patient goes in for a toxicity. So local anesthetic toxicity, as I already told you, there is a perioral numbness, tinnitus, lightheadedness, confusion, and then it ends up in seizure and finally in coma. And then at subsequent doses, for example, lidocaine, CNS comes first, and then it's the CVS toxicity. It all depends upon the toxicity. All depends upon the agent used and the dosage. When you're exceeding the per kg dosage, maximum dosage, and And again, when you're not using a vasoconstrictor, and when the already the pH is acidic in the patient, and your rapid administration, intravascular, all the injection sites, all these matter for the local anesthetic toxicity. The other side effects, as we already discussed, are allergic side effects, methemoglobinemia, paresthesia. Coming to the local anesthetic systemic toxicity, the first thing is that we have to support the ventilation. It goes on for this ABC protocol. And then for stopping the seizures, it's better to use benzodiazepines. It is better to avoid propofol. We have to initiate the cardiovascular life support protocols by starting the lipid therapy if the patient is not stable with all these supports. So the bolus intralipid is essentially started at 1.5 ml per kg bolus, and subsequent infusion dosage is 0.25 ml per kg per minute. And again, the scenario has to be assessed whether the patient is going for is still cardiovascular, still unstable. So we'll repeat the bolus at 1.5 ml per kg, and we have to assess for hypotension also. We should continuously monitor, and we have to monitor at least after 2 hours, even if the patient becomes cardiovascular stable. We should not exceed 12 ml per kg of lipid. And the total volume of the lipid emulsion can approach, in prolonged resuscitation, can approach up to even 1 liter. Thank you.
Very nice presentation.
Thank you. Can you hear me? Hello, can you hear me?
Yes, sir. Yes, sir.
Sorry. Very nice presentation, Dr. I have elaborated the things. It's a complex topic. You made it very simple, and some queries there. Is there a role of bicarbonate when it gets added to ropivacaine or bupivacaine to foster the onset of?
With the hydrochloride salts of the local anesthetic, addition of soda bicarb is found to be helpful. But nowadays, since we are injecting the local anesthetic very near to the nerve fibers using ultrasound guidance, the onset delay is actually totally eliminated. And so it is not much of clinical use nowadays, addition of soda bicarb.
These are all, this is my questions actually. We have seen surgeons using a lot of local anesthetics, concomitant anesthesia, and you are giving that local anesthetic dose should not exceed, say, for example, bupivacaine, you told 2 to 3 milligrams per kg body weight. But we had seen surgeons taking 2 or 3 ampoules of local anesthetic and diluting it to nearly 500 ml and injecting it. So, what is the rationale behind it? The concomitant anesthesia.
Dilute concentrations, because the total dosage is not exceeded. At dilute concentrations, the blockade of the nerve fibers is comparatively less when compared to the more concentrated local anesthetic. And usually the systemic absorption is less with dilute concentrations. And that's why it's used for tumescent.
Okay, so we had come across a lot of scenarios where we used to give local anesthetic for block, and in the middle of the surgery, surgeons used to infiltrate. For example, if in PKR and all, they used to give a lot of local anesthetic for local infiltration analgesia, where we would have given some 20 to 30 ml for our block. So how to explain it? Like, is it going for toxicity, or should be very careful in doing blocks?
So the initial rate of absorption is very important. The site of administration is also very important. Comparatively less vascular regions such as in knee, there is a very minimal absorption of the local anesthetic, and hence the toxicity is not reached.
So, so you mean to say that depends upon the vascular absorption. So if it is a delayed administration, then we can go ahead with the administration. Is there any methodology to identify the plasma concentration of local anesthetic?
Yes, sir. It can be identified by drawing blood samples, but it's not routinely done.
Okay, it is not our routine practice. What is the role of that intralipid in local anesthetic toxicity? Is it lipid sinking or some other?
It is lipid sinking. Actually, it draws the local anesthetic towards itself, and so it increases the dissociation from the receptors. So the much less amount of local anesthetic is available to bind with the target, the organs, and so that's how the concentration is reduced by an equilibrium shift.
This is a very common question from for the postgraduate. Like when you give spinal anesthesia for TURBT cases, and still the patient gets operator jet. So where should be the local anesthetics, and what is the rationale in that local anesthetic administration in central neuraxial blockade? And
So I don't get.
no, related to the operator jerk. Yeah. Same mechanism, right? Local anesthetic we are deposited in the central neuraxial blockade, but still the patient develops operator jerk.
Yes, sir.
No, why? What is it? Is there any role for the local anesthetic there?
We usually give a separate operator block in such cases. I'm not sure about the reasons, sir.
Okay. No, this is a very common question for.
Yeah, Professor, you can explain.
This is a very common question for from the examiner for the postgraduates. Like even then we are given a conduction blockade at the level of central neuraxium, the peripheral nerves are still intact. Still peripheral nerves are intact. The ion channels are still intact. So we can stimulate the nerves when there is a supramaximal stimulus. We can still stimulate the nerve and the nerves get stimulated. So for example, if you give spinal anesthesia, you can still stimulate the nerve peripherally and you can give femoral nerve block. The same mechanism when the bladder tumor is getting resected, when they go near the lateral wall, where the operator nerve exactly lies when there is a supramaximal stimulus, that operator nerve is getting stimulated and it produces the jet. So that is why we have to separately do an operator nerve block to avoid that jet. And
yes, I want to add that likewise the brachial plexus block also, if you stimulate the nerves distally, median nerve, radial nerve, you will get a motor response. So the thing is, the nerve the conduction is blocked, can be blocked at different level. But when you stimulate the nerve, the same nerve, in the distal, you can still get the motor response. So that is the basic mechanism. Okay,
Madam, your experience on ropivacaine in spinal anesthesia as a local anesthetic, ropivacaine in spinal anesthesia. No, very recently.
Hyperbaric ropivacaine is available for spinal anesthesia, sir.
No, will there be any difference between the bupivacaine?
The onset is comparatively, the onset is a little delayed, but the duration of action is prolonged.
Okay, okay. Sir, Kumar sir, you want to add up any points to this?
The intrathecal ropivacaine hyperbaric. Am I audible, Rajesh?
Yes, sir. Yes, sir. Yes, sir.
The intrathecal hyperbaric ropivacaine is introduced recently. Before that, so many of us tried that drug intrathecally, but the problem is the lack of motor blockade. Even though the sensory blockade is comparable with the bupivacaine, the motor blockade was very much less than compared in the bupivacaine. That's why the procedures which like orthopedic procedures where need a bit of a muscle relaxation or lock state, it is not the drug of choice. It's my personal experience and it was obviously accepted by all of us. I don't know the recent intrathecal hyperbaric ropivacaine how it acts, but anyhow we we are under the trial of the drug for the cesarean sections. One of our postgraduates is doing his thesis. So the larger volume of the things which may definitely, if the obstetricians are satisfied, I think that will be the that will throw some lights. Anyhow, who are using that extensively ropivacaine hyperbaric, can share their views on, especially the amount of the motor blockade comparable with the BOPE. I think it is not much comparable, especially the motor blockade part.
Sir, regarding orthopedic surgeries, I used to use ropivacaine, but I stopped it using for foot and ankle surgery. So it's for hip surgeries, yes, it does good wonders, but definitely not a drug of choice for foot and ankle surgeries because of the density of less density of motor blockade, and patients still move the toes, and it will be irritating for the surgeon. But they claim that it is a highly cardiac stable drug, but I don't know about how much it is more cardiac stable compared to bupivacaine.
So that is probably because of the slow onset of sympathetic and motor blockade. Patient has time to adjust with the hemodynamic changes, sir. Rapid, like if you put lignocaine, rapid fall will be there. Patient will have all problems. Because of the slow onset, probably it allows the hemodynamics to balance itself.
Yes, sir. It's a less blockade compared to the bupivacaine, so less hemodynamic changes.
So will there be alteration in the duration of action also, sir, because of this? The duration of action, madam told ropivacaine is a long-acting drug. It will be the same in spinal anesthesia, or it will become a short-acting drug in spine?
It's like a sensory blockade. The duration of the analgesia is comparable with the bupivacaine. We don't find any statistically advantages over the bupivacaine. Using the peripheral nerve blocks, especially, or some other continuous epidural continuous infusions. If you have the L-bupivacaine, that's okay. If you don't have the L-bupivacaine, better to choose the ropivacaine. Will be my drug of choice when L-bupivacaine is not available, because the safest local anesthetic right now we have the ropivacaine and the L-bupivacaine. If you don't have the L-bupivacaine, you can always choose the ropivacaine. That will be the better choice when we are comparing only the post-operative pain relief. And we are now started using the ropivacaine for all our chronic pain, trial block, and other things, because we found very safe than that of the bupivacaine. The L-bupivacaine is not available.
Shiva, any other?
Yes, sir. Can I add 3 more points, sir? The first is a review article about the safety and efficacy of additives and adjuvants in local anesthetics, sir. They have come up with some recommendations. So when we use a central neuraxial blockade, they always recommend safe and monitored opioids, because using dexmedetomidine causes more hemodynamic changes. When it comes to facial plane blocks, they recommend dexmedetomidine as an adjuvant, because that is much more safer in that plane when they give it, and it allows the blocks to be more prolonged. When it comes to nerve or plexus blocks, they recommend dexamethasone, sir. So these three given on individual basis forms a good additive practice. So that is one point which I wanted to add, sir. The second one is on adding soda bicarbonate to local anesthetics. They found that, as madam said, 1 ml of soda bicarbonate to lignocaine is fine, but giving it on ropivacaine and bupivacaine doesn't seem to have any additive effect, it seems. The actual dose, recommended dose, is 0.05 ml for 10 ml of bupivacaine, and they have also stated that in case ropivacaine precipitates, it is of no use. In case bupivacaine precipitates, maybe it has its effect, sir. Lignocaine, there is no change, but if it is ropivacaine, the ropivacaine becomes useless. The third point I wanted to add is there is one local anesthetic which was discovered in India itself by CDRA. It is called sentbucridine. We had this drug some time ago, but I don't know whether it is available now. We did a thesis on that sentbucridine. It is recommended for infiltration anesthesia. It is much more safer than all these local anesthetics. Thank you, sir.
Sir, one last question. Is there any role of ropivacaine in bias block? Madam, is there?
Bias block, since we inject the local anesthetic intravascular, only lignocaine is considered safe. It has not been tried on ropivacaine, and usually other local anesthetics are not preferred because they have the more CC by CNS ratio. Their cardiovascular toxicity is higher compared to lignocaine.
So, can I, if there is no other questions, can we start the next session, sir?
Yes, sir.
Thank you, madam. Thank you, Dr. Aishwarya, for your nice presentation and explanation of all our queries. Thank you. Thanks a lot. So we'll go ahead with our next session, which is about multimodal analgesia. And the presenter is Professor Dr. G.P. Kumar, sir, who doesn't need actually much introduction because he's a very eminent speaker and a known person in the Society of Anesthesiology and Pain Medicine. And he's a pioneer of actually pain medicine in Tamil Nadu, because long time back itself he started his own pain clinic at Chennai. Previously he was practicing in Madurai, and I still remember his words in 2010 when I met him as a junior of him in pain medicine. He told like this is the one pain which has to be which has to get developed more. So for the same reason we moved from Madurai to Chennai. Such a passionate person towards pain medicine, and right now he is a director of Indian Institute of Pain Management, and he had done more excellent works in pain medicine, and is establishing 4 chronic pain management clinics in government hospital. I think one has already got into at Omandura, and recently launched as FNB pain medicine course also. Over to you, G.K. Kumar sir, for the topic of multimodal analgesia.
Thank you very much, and thanks a lot for the ASA for providing such an opportunity to my institution to taking part in this wonderful academic. My special thanks to Edward Johnson, sir, because we share the same alma mater. Thanks for the opportunity. Can you see my slides?
Yes, sir.
Yes, sir.
Are you able to see my slides? Yes. Audio is okay?
Yes, sir. Yes, sir. Everything fine, sir.
Yeah. Thank you. Thanks a lot. So multimodal analgesia is going to discuss it. This is going as far as this topic, I'm going to restrict on acute pain management, because chronic pain management will be dealt by different ways. This is a multimodal analgesia regarding the acute pain management going to be the topic for 30 to 45 minutes. So whenever the pain, I start the things, whether the acute chronic, I would like to share this, one of my favorite slides. It will be there in all my presentations. It will speaks for itself. This guy, can you see my cursor?
Yes.
Are you able to see my cursor?
Yes, sir.
Yes, sir.
Okay.
Yes, sir. We can see that.
Boy hanging on in hooks definitely has all the reason for suffering with the pain. The nociception is there. This gentleman also entered with some other RTA and had the sorrow, the suffering is seen in the face, and there is obvious evidence he is suffering with the pain. The same nociception is here, the same injury is here, but this man is suffering with the pain, but this boy is not at all suffering with the pain. He is nicely posing to the camera and is enjoying, of course. So the most important thing everybody should know that pain and nociceptions are entirely different. For pain, there should not be the nociception. For every nociception, there should not be the pain perception. Previously, we are all dependent on the biomedical. We all believe that nociception and pain are same. If there is any stimuli, the patient should suffer. If there is any suffering, there should be some stimuli. That was the thought. Now that was changed to biopsychosocial model. Why I am emphasizing now? Biomedical model taught us to give one drug, pain relief is. That was our thought previously, but it proved entirely wrong, because we are giving one drug, 2 drugs, but the patient is still suffering with not only the acute pain, it ended up with the long-term suffering, that is chronic pain. So now it's because the biophysical, social, psychological, all the elements are there in perception of the pain. That's why it moved to biopsychosocial model. That's why the concept of multimodal was born. So the pain relief, you know that obvious benefit it has. If you're not going to relieve, there is an obvious catastrophes are there. The one of the things is prompts the early healing of the seizures. Most probably after the trauma and after the surgery, patient will have the acute pain. So it prompts the early healing and reduce the patient's response and shorten the hospital and length of the stay, and thereby the lower the cost. This is the risk of the chronic pain due to the neuroplasticity. If you're not treating the acute pain, there is a 25% of risk for developing the chronic pain is there, which is very difficult not to grab. Ultimately, the pain reduction of the pain during the acute procedures reduce the rate of morbidity and mortality. So the acute postoperative pain, this is a wonderful study. The same thing was conducted in 2010, almost 2010 to 20, 2011, 2020. The study proves that there is a Netherlands study shows 41% of the patients has moderate severe pain during the hospital stay, and that the same was there even after the 10 years. The 2020 studies also show. So we are still lacking behind providing the excellent postoperative pain care for the patients who underwent the surgeries. This postoperative pain includes the first 2 days. So this 48% of the patients still suffer with the first postoperative day, and 90% reported severe. The same, almost the same statistics still we are having that. So what are the painful truth in trauma patients? Pain is the prime complaint of the trauma patients. 90% of the patients suffering with the pain in the emergency department. 70% of the patients are discharged with the severe pain. And only 14 these are the little bit variable depending upon the institutional variations and depending upon the injury variation. So almost 1/3 of the patients only receive the analgesics for moderate to severe pain. So the ultimate aim is we have to alleviate the acute pain at any cost. Then let's see how this multimodal analgesia going to help us to achieve this goal. Another 30 minutes, the key point will be wobbling around multimodal analgesia, but we have to discuss to achieve the multimodal. The path to multimodal analgesia will be there. You have to identify, assess the acute pain, and what are the challenges in the acute pain management, and of course the multimodal analgesia, and what are the recent and future developments are going to come to help us to achieve that acute alleviation of the acute pain in complete sense. So the pain is the definition we have to know that it is because this was recently modified after the long 40 to 50 years first definition. This is an unpleasant sensory. It is no other definition is accepted in the world other than the ISP. So this is the recent 2019-20 the task force modified that. Earliest was presented in 1979, I think. So the unpleasant sensory emotional experience associated with or resembling that associated with actual or potential is. What does it mean? Pain is a personal experience. As I said, influenced by the biopsychosocial factors. Need not to be the all the time you have to search for the potential tissue or tissue damage. Need not search for the any potential tissue damage is going around for the patients. So etiology, out any tissue damage for the reason for the pain, it doesn't mean that the patient is not suffering with the pain. So a person's reports and experiences of pain, it should be respected and accepted. That is the ultimate meaning of these 3 lines. So what are the challenges again, especially the acute postoperative pain? This is the Srinivasa Raja is the president of the IAC, and he brought a lot of facts to us. The cause is also multi-factorial, not a single factor. That's why the continuous paucity of the pain assessment and documentation is the prime cause is suggesting that. And another thing is the absence of specific written pain management protocol and deficiencies of the education of the pain management program and underuse of the effective analgesic techniques, and poor adherence to the available guidelines. These are all the common. What are the barriers we have to cross is always under-recognized and untreated. Clinicians have unfamiliarity with the assessment. Of course, if you're not assessing the pain, you cannot treat the pain. And delayed absent pain assessment also the important factor they justified. And the cultural belief is the pain is in front of the patient is underwent surgery. It is his part to suffer with the pain because the pain is inevitable. That is the cultural belief. Still, most of our clinicians are having that. And aversion to the opioid. That's another point I want to say. But if you give the drug, you think the patient should be pain-free from pain because you think 1 + 1 is always 2 in your mind, but it is not there in pain management. So I have given most of the things why the patient is screaming with the pain. Immediately the resident or the doctors, I have given everything, but the patient is persecution. That is the reason we are putting and escaping that. So what is the cultural belief? Is pain is inevitable. What is our cultural belief of the most of us are believing that the drug is acting, the patient is overreacting that. So this is the aversion of the opioids also one more thing. And of course, another thing is the aversion for looking for the alternative opioids also another factor, which is contributing biggest barrier to achieve the 100% pain relief. A delayed administration of the analgesic, one of the things which is very commonly followed, and a lack of the patient-centric approach because the pain is a biopsychosocial model. Individual patients vary with the same stimuli. So that's why the patient-centric approach is the target rather than the disease-centric approach. The same appendectomy in different patients, post-operative pain scale will be very different. That's why it should be the patient-centric approach rather than the blanket approach for all the patients. So the acute pain management will be the multimodal approach. Before that, you have to assess the pain. Unless you assess the pain, you cannot magnitude the pain. And unless you magnitude the pain, it is very difficult to what is the drug to be given, how much to be given, what are the aggressive methods we have to go beyond that thing. And that's why the multimodal approach will help us to achieve the acute pain management in full way. What are the multimodal approach? One is the pharmacological multimodal approach, that is otherwise called multimodal analgesia. Then interventional multimodal approach, that is the thing. Also that the multimodal analgesia may be used in interventional technique also because as the previous speaker Aishwarya told, the adjuvants, the different combination of the drugs, not only the oral, intravenous, muscular, as well as the other routes also will help us to achieve this multimodal approach. The multimodal approach can be achieved in all other routes also that. So that is called interventions, peripheral nerve blocks and central nerve cell pocket can do find out the wonderful combination of the drugs which may enhance each action and thereby reduce their individual side effects and thereby allowing us to achieve the good pain relief for our patients. So the assessment of the pain is the key thing I suggest the body how to do the pain assessment. The simple thing O, P, Q, R, S, T, mnemonics. O is the onset, P is the provocation and pain relief. That is the what are the factors will increase the pain, what are the factors will decrease the pain, especially useful activity related pain and quality of the pain. Whether the pain is very severe and other things where we have that scoring may help us to think also. And the same thing also neuropathic pain. The patient will have that chronic pain patient coming for the some other trauma. The patient will have the blend of the acute and chronic pain features. All the things we have to find out. Unless you go through this systematic manner, you definitely miss that. And very difficult to treat the patient, chronic pain patient coming for acute pain management. And region and radiation also we have to come in mind. Severity, what is the time, how long the patient is suffering with the pain. All the things are simply go through that within a minute. OPQRST, mnemonics. And there is so many pain scale is there. Unidimensional pain is there. Scale is there for acute pain management. It's very easy and simply worldwide the mostly followed one. And multiple Megill's pain score is especially for the neuropathic and chronic pain. It is just that so many questionnaires. We have to find out which one is the dominant acute pain, nociceptive pain, neuroplastic, neuropathic pain, or the mixed pain is that. That's why you can modify your treatment. pain assessment in normal, non-verbal patient cannot communicate with you. You can take the algo patient with the dementia. Pain art scale is there, all the things you can refer and how to apply that. Unidimensional scale is the one which is usually followed with the numerical rating scale and pain intensity scale, visual analog scale, all the things are. This is the facial pain scale is also there, very much useful for the pediatric age group. So anyone you have to use it unless you assess the pain and things very difficult to move for the next step. The multimodal approach. What do you mean by the as I said early, this is the patient-centric approach. That includes multimodal analgesia, use of variety of analgesic medications and techniques for the treatment of the acute pain. That is definition. You can take it as a definition. There is no proper definition, only the description that should be individualized to the patients. And it depends upon the mechanism of the pain, mostly acute pain mechanisms. The patients come in chronic pain and acute pain. Chronic, already suffering with the chronic pain, superadded with the acute pain, that we have to take care of that. Location of the pain, depending upon the type of the surgical and depending upon the expected duration of the pain, all the things you have to consider before taking the multimodal analgesia. What is the drug? What is the technique? How much the thing to be needed? What is the dose to be administered? All the things come. You have to decide, and it should be tailored for each and every individual patients. So multimodal analgesia mean to capture the effectiveness of the individual drugs, that is in optimal doses to attain the maximal efficacy, at the same time reducing the side effects. So you are blending with the one or two drugs, at the same time reducing the doses and maximizing the each other drugs complement to each other, that is called synergistic effect. Thereby reducing the side effects of the individual drugs and thereby increasing the duration of and quality of the analgesia for the particular patient. That is called multimodal analgesia, because all depends upon of the how the drugs work along the pain pathway. This concept is based on the theory that the agent different mechanism from analgesia that may have the synergistic effect in preventing or treating the acute pain when used in combinations. Then we have to differentiate between the multimodal and polypharmacy. This is the most important thing, especially for the postgraduates. The multimodal is based on the rational combination of the optimal doses of the different drugs in different drugs. Whereas the use of the multiple medications more than therapeutically necessary, that is called polypharmacy. It provides the multimodal provides the way to achieve the safer and more effective, of course, sometimes opioid sparing pain management. Whereas these multiple drugs, medications, same class, same mode of actions, we are choosing that. So potentially inoperative excessive administration of the, so it's entirely opposite. This is the one part of the multimodal analysis, the safe way and more scientific, more systematic usage of the polypharmacy. So multimodal analysis, what are the uses of that? What is the advantages? Why it is needed? Of course, it optimizes the pain relief, reduces the side effect burdens because each drug has the side effects. So sometimes it will reduce us or it will prevent us to use that particular drugs and provide synergetics and additive. The most important why we are combining some other drug is the synergistic effect. Lower dose of each medications are achievable. That has the opioid sparing pain control. Now the whole world is playing around the opioid-free anesthesia or pain relief, and it prevents the central sensitivity, of course, the chronic pain process. So what are the pharmacological drugs available? What are the analgesic tools we have that for mild to moderate pain, we can choose anything. This one doesn't mean you should choose the, you have to, your thing should be within this toolbox. It is not like that. It is just a guidelines that for severe pain, we need some kind of the opioids for all the time. But doesn't mean that means all the time the opioid should be for when the VA score is more than 6. This is general guidelines. So the multimodal analysis, I said, it is a targets along the pain pathway. It's a very simple one. What are the pain pathway? Transduction, something happens in the peripheral receptors. Transmission is nothing but the passage of the action potential along the peripheral nerves. up to the level of the spinal cord and transmitted above the tracts to the perception centers. So this is the transsection, this is the transmission, and it has the descending modulations, that descending fibers. If these descending fibers alters the pain conduction in different ways, central and as well as the peripheral. That is called a modulation. This is a descending model. This descending model will help us to reduce the further conduction or intensity, at the same time the duration, I mean the intensity of the pain which is conducted to be subsequently conducted will be reduced by the process of the modulation. These are the natural defense mechanism. So when you're doing that, giving the drug this level, this is called multimodal. Not only giving the drugs which is centrally acting, not only they giving the drug which is the blocks which is prevent the transmission of the peripheral nerve blocks, not only local infiltrations, or not only giving the central neuraxial. If you are giving centrally acting drugs and if you have the enhances the modulations, that means it has the multimodal. The multimodal nothing but the targeting to treat the pain along its pain pathway. That is called multimodal. So these are all the drugs which is acting on peripheral various levels, dorsal horn level and peripheral sensitization, central sensitization, descending modulation. So many drugs are there. This is just a bird's eye view, and this is the exact thing where the drugs is working. The transduction level working the local anesthetics, NSAIDs, opioids, antihistaminics, and the capsaicin. All the things are working around the level of the transductions. And transmissions, of course, you know, the local anesthetics, opioids, alpha-2 agonists, and the GABA pentinoids, NMDA receptor antagonists, because various receptors and chemical neurotransmitters are involved in the pain transmission. That's why these drugs are acting in different receptors on different level. And that's why we need because the pain transmission is not a simple one as we thinking. It has the different way of achieving the pain perception. That's why we have the different level of receptors, different pathways to block that pain conduction and reduce the pain suffering. And descending modulation, I said it has the enhances the descending modulations, OPIs, acetaminophen, COX-2 inhibitor, SNRI, NMDR antagonists, and the perception level. These are all the drugs are acting that. That is why if we select one drug each level, and of course the local anesthetic acts in this level, the opioids act in this level. If you combine this local anesthetic, local opioids, almost you will achieve that all the levels of the things. And if you're adding one more NMDA antagonist, and you can pick one each level, and you can have that. That is called multimodal, and it's acting or selecting the drugs and different level at the same time, reducing the doses of each other to make a synergistic effect, and thereby achieving the good pain relief as far as possible. The same thing is a little bit elaborative. The drug alpha-2 agonist, dexmedetomidine, the clonidine is there. Now the dexmedetomidine is the scores over the clonidine for the obvious reason of the more less side effects, especially the hypotension and bradycardia. The anticonversions most commonly used multimodal anesthesia, even for acute pain, is the pregabalin and gabapentin. I will come to later how much the drugs to dose and other things. What are the real scenario? All the things in synopsis I will come to later. NMDA agonist and local anesthesia were dealt by Aishwarya elaboratively. So acetaminophen is one of the drug which is there in all the post-operative pain management with the tramadol, and the NSAIDs. All the things are there, and which has to be exposed over that, then we will discuss in later and next coming slides. These are the common dosages are there, and of course mostly intravenous route is there. So the adjuvants which is neuraxial as well as the peripheral nerve block and field block, the adjuvants are drugs which will help us to prolong the duration of the local anesthetic drugs. The most common one is nowadays used with the favorable dexmedetomidine. Intrathecal 5 to 10 mg can be given, epidural 0.5 mg per ml, especially the pain relief during their pregnancies. There's all the things for this dose is selected. Peripheral nerve block, anything around 50 max is then given. For intrathecal, it is not much advisable, but it has the very, very popular choice for peripheral nerve block and epidural also that. The other thing adjuvants among the things which is the most promising one is dexamethasone. It's a very good drug for peripheral nerve block as well as the brachial plexus block. It has the proven one. It is the definitely studies are supporting us to use the dexamethasone 8 milligram whenever doing the peripheral nerve block. Other drugs are coming and going, and magnesium also coming intrathecally, but it is not advisable to select these drugs as a first choice because still we have to find out a lot of studies to support us because all the things are acting through the NMDA receptors. And midazolam, of course, so many people are used that. Now it is not the, we are not widely used. Ketamine also going to be used, also it was also used, but still we are sticking in the IV ketamine or oral ketamine. It is not a good choice to add an adjuvants. And the good drugs right now is the moral of the story is among the adjuvants, dexamethasone and dexmedetomidine will be the better one than the other one. Of course, the opiates also can be used intrathecally as a local anesthetic to support the longer duration of the action. The choice will come as the morphine, but it has a lot of side effects, and especially the delayed respiratory depression one we have to keep in mind. But intrathecal epidural is the one which is widely used for peripheral nerve blocks, not much useful. So the tramadol very useful for epidural. Other drugs are fentanyl very much promotes the intrathecal and epidural. So peripheral nerve blocks, even though a lot of studies are there, but it is not going to be beneficial. So morphine, epidural will be useful. Fentanyl, intrathecal adjuvants widely used, and epidural can be used. And so fentanyl not widely available in our part, and buprenorphine is not at all using nowadays because of the side effects. Now the only way we are using the transdermal patches, and tramadol is also not much encouraging when comparing with the IV route and the epidural. Also little bit of comparable with the IV route only, but still widely used. So I'm coming to the each and every one. Acetaminophen and NSAID is the most common drug combination of the analgesics for multimodal. Is one of the unavoidable drug, but it has the reason for that, and it's approved to be. It has the work to be selected. NSAID has a limited oral period. That's why intranasal ketorolac also has come up. And some IV ketorolac, anyhow, we don't much use the oral NSAIDs for a preoperative period. That's why the drug which has the IV route is IV ketorolac, IV ibuprofen. Ibuprofen is also available, but it's not available in our part of the country. The IV ketorolac, most of the first used, and IV diclofenac is also available, but I don't have much experience of the IV diclofenac and IV ibuprofen. IV ketorolac is the good choice. Even it can be used for the pediatric age group. The IV ketorolac. A lot of studies are there, especially the post-tonsillectomy cases. So, what are the drug you are choosing? You have to be clear indication, correct dose, and to be added with acetaminophen will definitely have the added advantage. The next common drug which is used the anti-conversion. But it is the dose which is administered is very high. It's 900 milligram, 1200 milligram preoperatively, 24 hours of the things. But it doesn't have that more than 24 hours because it has given a single dose. We cannot administer these drugs post-operative. Also, that so many limitations are there. But it has the severe hangover and sedative side effect is that. But I doubt whether the Indian patients are will tolerate 900 or 2,000 because we are giving this drug, even 100 mg, the patient will complain of the hangover the next day. So I really suspect whether these doses will be comfortably tolerated by the patient. But the choice will be the 150 milligram 1 hour preoperatively, may will be the better choice than the gabapentin in 1200 milligram or 900 milligram. But it doesn't have the great studies are not much encouraging to use as a regular practice because of the side effects. Second one is that it has the longer duration post-operative pain relief, and the chronic sensitization reduction is the rather than the acute pain management. But it significant studies shows that a significant narcotic consumption is there in first 24 hours. So if you want to use the anticonvulsant, the drug of choice in the pregabalin 150 milligram orally, 1 hour, that is a single dose, will be the ideal one. And capsaicin is the another, which is the another drug which is very much going to be useful in coming days, because it is a small liquid. It comes as you can use as a local wound infiltration, especially some studies are available for the after the hernia repair, after putting the machine, they have installation of the 1000 milligram of the capsaicin. Because it is not non-narcotic and acting through the vanillin receptor, TRPV1 receptor agonist, not affecting the aid and duct. So it is a different kind of the mechanism. So definitely it may be a useful one, which still we need a lot of studies to make it is a standard practice, and the widely available of the drug also the another factor to be considered. Capsaicin, these drugs are definitely desensitization, so it may reduce the development of the chronic pain in future. So still it is useful for the diabetic neuropathic patient and post-herpetic neuralgia. So the another fascinating drugs is always thinking of the receptor antagonism and with the multimodal analgesia technique. For I think ketamine is the drug, but it has the limitation of psychiatric side effects. Ketamine infusion of the 10 milligram per kg per minute at the beginning of the surgery and bolus of these the common one drug prescribed if you want to ketamine for the reasons of to avoid the especially the amputation patients to avoid the post stump pain, post surgical stump pain or the phantom pain. It definitely it reduces the incidence of the development of the chronic CRPS pain syndromes, but doesn't have that acutely reduces the consumptions of opioid during the post-operative period, but it has the lower pain scores up to the week of the operation. So, but it is mainly chosen for long-term preventive pain rather than the acute pain management around the immediate post-operative period. Memantine is the orally considered non-competitive NMW receptors, but it is used for the schizophrenic patients. But the prescribed dose, we have to achieve the 30 milligram. But achieving the 30 milligram is not an easy one because the starting dose is 5 milligram. It has to be escalated every 2 to 3 days. To achieve the 30 milligram will take 2 to 3 weeks. But it has promising results in decreasing the phantom pain, but it doesn't have any role of post-operative pain. So right now, the NMDA receptor antagonist, ketamine, have very limited usage. Memantine is a long way to go for us to choose this drug. But the magnesium is a promising results. It also acts through the NMDA receptors, 50 milligram administered intrathecally, but we have to do the studies. There are a few studies only available for this one, but IV magnesium at 40 before induction followed by as a widely used, it has the promising results, result in reduction of the perioperative analgesic requirements. On to NMDA receptors, the choice will be among the drugs ketamine, memantine. The magnesium will be the better choice, that too or the IV rather than going for some other routes. These are the things available at present. So now for to agonist, the most fascinating one is the in our days we so always use the clonidine whatever we are doing, that intrathecal, peripheral nerve blocks. Even if you are giving the laparoscopic general anesthesia, the clonidine will be there in our drug box. but now the dexamethasone almost replaces the clonidine because it has the versatile IV central neuroaxial blockade and peripheral blockade also that. So it is the one of the drugs, but intrathecal is simply I remember 5.5 50 max. It's intrathecal, but intrathecal usage is very much limited. Before you select, you have to think twice, thrice for dexamethasone because some other drugs are available for intrathecal adjuvants. For this is the epidural for especially labor analgesia 0.5 max per ml. You can use it. The 50 max is the perineal blockade. Definitely increase the duration of the your peripheral nerve blockade in longer way than the drug is given along with the local anesthetics. So dual acting drugs, which is the dependent or still available only the oral. It was very fascinating. We had a great hope when it was introduced a few years ago because it's a dual analgesic action. Mu opioid receptor as well as the norepinephrine. Single dose will take care of these two way of acting that, but it is not showing us. We thought of from it results in chronic pain as well as the acute pain, limited usage of in acute pain also. So dependent on not the drug for choice for selecting for the acute pain management. So what are the newer developments we are having this thing in them? The butyl aminobenzate, the ester, which has the longer duration of the local anesthetics, and tokenide and L-butyl tetrakenide, the duration of the prolonged essential. So single nerve block may taken care of the complete post-operative period. It may come as if you want to give the any perineal block, with these drugs, the patient will have the pain relief for 3 to 4 days, even for the longer duration beyond our expectation may come in future because of the drug delivery mechanisms, liposomal, microspheres, liposomal almost came up with almost there with other drugs for other therapeutic research, but still we are looking for that for analgesic local anesthetic as well as the opioids, which is based on liposomal drug delivery systems. Adenosines, one of the drugs is for analgesia medications, spinal adenosine receptors, but it doesn't have any significant neurotoxic effect in animal studies. We have to wait for the human trials and wait for that. The same thing is also dextrans, also prolong the duration of the analgesia. Whenever the local anesthetics combined with the dextrans, we may have that longer duration acting local anesthetics. So these are the longer duration of the action is prolonged by different methods, but different kind of the deliveries. Both patient controlled analgesia, intranasal, intradermal, transdermal, and intraoffice, all the things, transpulmonary puffs, all the things are going to come in future to make us the simple multimodal analgesia. Aerosolized liposome, fentanyl, morphine, things may come with just one puff will reduce the post-operative pain and without much complications. That is the most important thing we have to look for. The things will be easier going for us if these things are going to come in clinical uses. Already we have that oral transmucosal phenyl citrate, especially this was very useful for the lollipops for the post-operative pain relief in the pediatric age group. It was very promisingly there in few years ago, but I don't know that is now it is very difficult to find out because of the it is not used widely in India. That's why it's again very difficult to. But Depadur is the extended release of the epidural morphine. It is still few study purpose. The FDA has approved this thing, but it has to come to our clinical practice to make it as viable for regular usage. So genotype-based pain therapy is the going to be the game changer. It is very much described in a 2011 article by Srinivasa Raja. But these are all the things are wobbling around the genotype, MIG, opioid receptors, and the cytochrome. All the things are there. And if you decoding or coding or correction things will make us favorable for us to the patient is should have the pain relief. Previously, for an example, complete inability can be modified by these mutations need the pro-drug active. Suppose the drug is the patient will not having good effect. If you change this thing one, the patient will have that put in responsive. And again, same thing can be done with reduce their side effects also. The prostaglandin responsiveness can be also enhanced by this modifying this. This is long way to go. If this is going to, that is also very much good to us to come. Then the take-home message will be the what should be there in your analysis tool. What should be there in your cocktail for the multimodal analgesia? The concurrent use of the more than one class of analgesic drug or the technique to target the different mechanisms. If you're choosing the drug, definitely don't choose the two local anesthetics instead of local anesthetic and opioid. That is the way you have to choose the concurrent use of more than one class of analgesic drugs or technique to target the different mechanism of analgesia has been advocated to improve the analgesia through the additive or synergistic effect. There is no universal formula because it should be the patient-centric. There are the only options are that these are the drugs are out in the final call by you based on some scientific facts. So the acute pain guidelines also will add as to that these are the thing Journal of the Pain released 2016. So many recommendations are there. This recommends also use the peripheral regional anesthesia, which has a strong recommendation, high quality. Also use the peripheral regional continuous technique also can be used to prolong the pain relief as far as possible. And neuraxial therapies also, whenever possibilities in neuraxial anesthesia can be, techniques can be complemented in multimodal analgesia. So interventional regional drugs also scores its own place. I think what are the options are available, because after the advent of the ultrasound, we can know that wherever the plane we can infiltrate the local anesthetics with the adjuvants will increase the duration of the post-operative pain relief. All the things I conveniently leave all the things because it is at present it is out of thing. Okay, sorry for that, skipping the slides. So summary, pain is the prime symptom for the patients. So we have to treat it at any cost. Acute pain to be assessed and to be reviewed periodically. If you're not assessing the pains, you cannot treat the pain. Pain should be addressed within 20 minutes, 20 maximum half an hour. It has to be the initiation to be started. Treatment should be started within half an hour. Interventions options always available to be added if possible. Awareness and acquiring skill and application is the key for alleviate the acute pain. And acute pain management is vaccination for the chronic pain. Multimodal analgesia is there always. You have to think of acute pain. There is no universal formula for you to give it to you. It should be the patient-centric approach, and recent developments are promising. The game changer will be the genetic modulations. So with these things, I'll conclude my talk, and thanks for your wonderful opportunity and listening also there.
Thank you, Kumar sir. Thank you, Kumar sir, for your wonderful lecture. And shall we take on some questions, sir?
Yes.
Sir, you explained very well about this multimodal analgesia. There are some questions from the chat box. Say, when it should be given, the timing of multimodal analgesic drugs, whether it should be given before the incision or it should be given in any specific timing is there?
So the multimodal analgesia should be started and planned before while you are planning for intraoperative things. So it has to be some of the drugs to be given preoperatively also. So oral drugs, all the things. So it can be given, it planned during before giving. So at the time of ingestion also, or prior to also, you can give it.
Okay. Sir, what drugs do you prefer in your multimodal approach, particularly when you go for regional anesthesia in the form of either blocks or spinal anesthesia?
So the final is the most important. If you want to do that and select an opioid, the first choice will be the fentanyl. If you want to give any additives for epidural, the choice will be the opioid or dexmedetomidine. If you want the peripheral nerve block, especially the dexamethasone and dexmedetomidine will come as a choice.
Sir, is there any role of IV lidocaine in multimodal analysis?
Yes, IV lidocaine has the it doesn't have that acute thing. It will the mode of action for IV lidocaine is mainly sensitization. So it will reduce the immediate shifting of the acute pain to chronic pain and thereby reducing the chronic pain. So when the patient comes with the background of the chronic pain for acute pain relief, these drugs can be used as an alleviation of the sensitization, handling the sensitization. But acute pain, IV lidocaine, especially the analgesic parts, is limited.
I think your share is still, your screen is still on. Can you just close your screen? Because your face is not much visible to the audience.
Hello?
Sir, can you close your screen, sir? That laptop screen is still on.
Stop
One
sharing.
minute.
Stop sharing.
1 minute. I'll do you want to not to share now?
Yes, sir. Yes, sir. So that you are now this is beginning better. Sir, role of gabapentinoids in acute pain management.
I clearly told that the drug of choice, if you want to give the gabapentinoid, you have to give it preoperatively. That is single dose only. So the choice will have that the pregabalin or the gabapentin. Pregabalin 150 milligram 1 hour prior to the starting of anesthesia or general anesthesia will have that reduce the pain score during the first 24 hours only. It doesn't have that reducing the narcotic consumption during the perioperative period, but it has the sensitization prevention role is there. If the patient will development of the chronic pain, incidences are low when the patient consumed or given gabapentinoid preoperatively. Doesn't have any role of continuation of the gabapentinoids post-operative. It doesn't have any great benefit other than the side effects. When comparing with the other drugs, gabapentin, which we have to give around 900 to 1200 milligram to achieve the same effect. The Indian patients are going to be sensitive for this dose. So lot of nausea, vomiting, as well as the hangover will be there in perioperative period. So the choice is very much limited to restrict the dose around 150 milligram of pregabalin rather than the choosing the gabapentin, because the pregabalin has a better bioavailability than the gabapentin.
Sir, what is your take on IV paracetamol? Because there are a lot of preparations coming with from a lot of companies, and they look little costly also. So does it have a good role in acute pain management, or does it have a big role in multimodal analgesia to prevent the chronic pain?
The most unavoidable drug you have to choose the multimodal is the other than the opioid is acetaminophen and is the NSAID. You have to choose any one of these things. So acetaminophen alone rather than using the acetaminophen alone, acetaminophen with NSAIDs will have that, definitely will have that great added advantages of that way reducing the post-operative narcotic consumptions, that way reducing the narcotic related complications. At the same time, it has the safety profile also, especially ibuprofen with the paracetamol combinations both the things are ketorolac and acetaminophen combination is very much useful in the pediatric age group. Anything around 30 milligram per kg of IV paracetamol in divided doses, 30 to 50 also that. At the same time, you can add 10 to 15 milligram of ketorolac also will have that definitely good role. And studies are encouraging to combination of the NSAIDs with acetaminophen. Definitely, it has the role in perioperative, especially the post-operative management. It has definite role in multimodal anesthesia.
Does duloxetine has any role in acute pain?
No, duloxetine has no role. That's why I conveniently left out the duloxetine. And the equivalent drug dependadol also tried in so many trials. It doesn't have any role in doesn't have any role. The duloxetine, don't waste your time and money on trying the duloxetine. Studies also not.
Is there any role for transdermal patches in multimodal approach of pain management? Transdermal patches in the form of fentanyl or buprenorphine. If so, what is the recommendation and what is the precaution we have to take?
Yes, transdermal patches are widely available in all drugs, local anesthetics, opioids, NSAIDs, all the things are available. We won't rule that, especially I preferably using the procedural when you after giving the small incision to place the catheters or something, you can put it that definitely it has the roles are that, but it has its limitations. It doesn't only the if you know that it's only the transduction level acting, that it doesn't act beyond the level of the transduction. If you have that no nociception, no receptor stimulation, it won't act. So deeper level, it won't act. So only the cutaneous nociceptors level, it will act.
Kumar sir, do you have any experience over capsaicin infiltration? Capsaicin wound infiltration.
Capsaicin is it's not available. I never used that. I just read in books, and it may comes in. It's only available. I'm using as a ointment only. Still, that wound infiltration solutions, I don't think it's available in India. If it is available, we can try that. But the results are a little bit promising that it will replace the local infiltration in due course.
Sir, you mentioned about epidural fentanyl you prefer. Will you use the same dose for pediatric and adult, the same 2 to 4 micrograms per ml dilution for both pediatrics?
So depending upon which concentration of the local anesthetics you are going to use it, if you are doing the lower local anesthetic concentration, you can go up to the 2 mics per ml. If you are using the local anesthetic is higher concentration, more than 0.5 mics, around 0.5 milligram, 0.5%, you can reduce the fentanyl around 1 mics per kg, 1 mics per ml. That is the usual recommendations. I am not aware of that pediatric. If anybody has some other points, I'll be happy to hear that also. That I'm not very sure about the current recommendation in pediatrics.
Okay, sir. I think we have taken up almost all the questions, sir. There are some common questions and comments. One comment from Partha sir that quoting that about ropivacaine, if it doesn't have any specific benefits over other spinal anesthetic drugs, it is going to be out of market soon. So that is what he makes a comment on. Ropivacaine heavy for spinal anesthesia. And Prema madam wants to know about levobupivacaine heavy, which is also recently launched. Levobupivacaine heavy. This is ropivacaine heavy.
Aishwarya, it's for you.
Aishwarya, Dr. Aishwarya.
Levobupivacaine hyperbaric has similar characteristics of hyperbaric bupivacaine, sir. The onset and the amount of blockade is very similar to bupivacaine profile.
So that looks a little promising than ropivacaine heavy.
Yes, sir.
Edward sir, any other questions you have?
Yeah, that's all, sir. Okay.
Shiva, any comments, Shiva?
Shiva has left.
Shiva has left. Okay, sir. Thank you, Kumar sir and Aishwarya madam. It's a very nice session. We had a wonderful lecture followed by discussion. Thank you very much, and thank you, Edward sir, for the opportunity. Thank you, Ananda.
Thank you,
Over to
Rajesh,
you,
sir,
Edward.
for wonderful coordination of this subject and discussion. I thank the speaker Aishwarya. He made a tailor-made presentation for the postgraduates. Very nice presentation, Aishwarya madam. And GK Kumar, as always, you are extensively cover the chronic pain. Now you come to the acute pain management discussion. Multinodal analgesia is a very vast subject. We are given a bad view about the multinodal analgesia very nicely for the postgraduates. Thank you once again, Aishwarya madam and GK Kumar, Rajesh sir. I thank the sponsors Acrola and A1 Logics and Anaesthesia TV. So we will meet next week with some more interesting topics. Thank you, Ananda.